That's actually what we want to do. We want to get people off of with blood pressure medicine or cholesterol medication or diabetic medication, right? That's what we want to do. And that's really what the GLP-1s are helping us do. With that said, I think you have to be really careful. One of the things, that's always concerning with compounding is safety. It's really dependent on who the compounder is and what their quality is and what their intentions are. We have seen, and I've already given you guys some examples of people using GLP-3 from China and overdosing.
Welcome to Dive into Health MD, the podcast where we explore how everyday habits shape your physical, cognitive, and financial well-being. Through conversations with physicians, scientists, and farmers, we explore how daily choices like food, movement, sleep, and mindset shape the health and life we experience, with special episodes on sourcing high-quality food ingredients. I'm your host, Dr. Akshita Mehta. Let's dive in. Dr. Krishna Vedala, I'm so excited to chat with you. Thanks for coming on to Dive into Health MD today. We are going to be talking about obesity medicine, GLP1s, all things related to kind of peptides and where obesity medicine is now. And I can't wait to get into it. Thanks for coming on.
No, thank you so much for having me on. And I'm really excited. I think we're going to have a wonderful talk. And we really are at the beginning of the cusp of a revolution in obesity medication. And there's so much we're going to talk about and how it's really transformed not just the obesity rates in our country, but also really in the way that healthcare business is done. And we'll get more into that throughout the show, but I'm excited. I'm really excited.
Awesome. Do you want to give us a little bit of an introduction into your background and who you are and what you do?
Sure. So my name is Dr. Krishna Vedala. I am based in Oklahoma City. I grew up in Oklahoma City all my life. Hence what my cousins tell me is I have a pretty strong Southern accent, although I don't think so. I don't think it's that Southern, but I'm board certified in internal medicine and obesity medicine. I'm currently a primary care physician. I do a few urgent care shifts here and there for some extra cash, but mostly just stick to primary care. I really loved hospital medicine, but then I was also kind of burnt out from the pandemic, and I decided, okay, this is not for me. And I also had a passion for oncology, but my wife was tired of me always studying and being in training, and she finally wanted to see me make the big bucks. And so I said, okay, primary care it is. And here we are. I also have a background in public health. Before getting into medical school, I did a master's in public health. And then as soon as I got into residency, I figured out that medicine is a lot about math, mostly just the money, right? And so I decided to get an MBA, and I finished that in 2024. I have a couple of different interests, mostly when it comes to public health, looking at the social determinants of health, and also trying to develop as a physician leader, which is kind of what I've done the last 5 years since being out of residency. And now I'm also the host of my own podcast, Connected by Health. And we have one son who is about 22 months old. And then we're expecting another one in August of 2026. And it's a boy. So we're going to have two boys, hopefully here by the end of next month. And life is going to get chaotic, but we're still going to try to continue to grow as a person and as a family.
Amazing. Congratulations.
Yeah, congrats.
My little ones are 22 months apart. It is a fun and wild ride, and I am so excited for you.
It is. It was a very fun ride. But everybody goes through it. Humanity has been having kids for millions of years, and we all just have to go through it. So
we all figure it out together.
Yep.
Awesome. So for your podcast, I'm happy to introduce myself as well. I am Dr. Akshita Mehta. I am a neuroradiologist. I also have a second board certification in lifestyle medicine. I am originally from DC. I grew up in Maryland in the suburbs of DC and am currently just outside of Austin in Texas. Interestingly, I did not grow up in the South, but people still tell me that I have a Southern accent. So who knows where that came from. But currently both practicing neuroradiology, but also started this company, Dive into Health MD, the name of this podcast. Where we talk about prevention. And a really big focus of the podcast is food in particular, food quality, sourcing quality food ingredients, and kind of the how behind the whole foods recommendation that a lot of physicians are talking about in terms of health today. And so it ties very much into medicine, and I'm excited to chat with you. And Div, do you want to introduce yourself?
Yeah. So I'm Divya Korean. I'm an emergency physician out in San Francisco. I actually kind of took a similar path to you in some ways. I did a lot of public health in medical school. I ended up doing a administration fellowship, started an MBA, didn't finish it. And then somehow pivoted to lifestyle medicine with Akshita. And so we've just kind of been digging into what other things there are in the world. I feel like we see just all the end stage of stuff in the emergency room. So it's been really nice to do a little bit more preventative stuff.
Yeah. My brother, who's also Dr. Veer Vedala, I have to mention my name so people can look him up. He's also actually, he's a family medicine physician, and he's also a lifestyle medicine board certified. So it's something I'm also looking at doing, and I encourage all of our listeners to look into. It's a really, really cool field that's really growing, and it is. He told me it wasn't bad taking the board exam, but I don't know. I'll let you guys know probably next year or the year after when I do it too. But you guys have already done this, so. But it's a really cool growing field, and I really encourage all of our listeners to look into it.
Yeah, it's not bad. It's not a bad certification for sure. Yeah, just to kind of mimic what Divya said, I just really seeing a lot of this end stage chronic disease, right? Especially as a radiologist, I'm looking at this stuff, hundreds of scans potentially in a day and seeing the same things over and over again. So it's fun to have conversations about the flip side of it, right? What can we do to prevent what almost feels inevitable as a physician? And so it's been really fun to dig into all these different areas that we didn't really cover in training.
Yeah, of course. It's just that it's how medicine works. There's only so much you learn in medical school and residency, and then you do continuous learning for the rest of your life. So always fun.
Always fun. Okay, so that's a really good segue into sort of our opening icebreaker question. So if someone followed you around for 24 hours, what would surprise them most?
I think they would be surprised by just how much my brain is on all the time. I'm primary care physician, and when I initially went into primary care, I thought it was going to be your typical 8 to 5 job, but that's really not the case. From the moment I walk in at 6:45 till the moment I'm out, and even after when I'm at home, there's always something I continuously try to do. And of course, I do get my 6 hours of sleep, 6 to 7 hours of sleep. It's not that I'm sleep deprived, but at the end of the day, there's just so much that goes on, and there's so much that you just have to keep going, and it's just a churn. You turn in and turn out, and you keep going and keep going. And that's really what primary care, I think, has become these days. And that's just the way the market and the way healthcare is being administered has just took it to.
Yeah, I think interesting insight for a lot of people to really get a little bit behind the scenes and understand what happens, right? Something that seems like an 8 to 4 or 9 to 4 clinic. There's so much more beyond that.
It's
Almost
really not. It's
yeah.
yeah.
That
It's
doesn't
like you have the hospitalist shift 7 off and 7 on. I kind of feel like I'm on most of the time. So, but it's fun. It's what I enjoy, right? I enjoy building relationships. I enjoy taking care of patients. I enjoy seeing them improve and achieve their goals. And so that's really what makes it fun, and that's really what makes it doable. But people are surprised as how much work is done behind the scenes in primary care.
Yeah.
I'm wondering if you're having a similar experience as some of my friends in primary care. They've been talking about how the patient portals with the messaging has been so revolutionary and good, but is really what's causing a lot of the extra strain post-shift.
It is. It really is. And this is what my brother and I calling pajama time, right? So there's the 8 to 5 when you're seeing patients, but then when you go home, there's always these messages, labs, documents you have to review. And then you're kind of worried about, if I missed this little detail, maybe I might miss something that's really pertinent and important. So there's really a lot that comes into it. But really, the portal service, the e-messaging, while it has been revolutionary, it may have cut down on work for the front staff and for some of the other ancillary staff. In the long run, I think it's really kind of put a lot on the physicians, because we're the ones that make the decisions. And even if you do have proper nursing staff that's trained well, it still is a liability issue. Okay, what if I happen to miss this because I gave the nurse permission just to say, oh, this is okay, but maybe it's not, right? Even something as simple as leukopenia, right? If you ignore it, you never know what's going to happen, right? So that's, to all of our listeners, leukopenia is low white blood cell count. So maybe I'm going to try to use as many layman terms as possible, but even something as a low white blood cell count isn't something you want to ignore, right? So that's really what's happening. It's just the pajama time for, I think, primary care physicians has exploded ever since we've introduced this whole electronic messaging system.
Yeah, incredible. Yeah, well, let's start talking a little bit about, some of the stuff that you're talking about in clinic.
Yeah.
And, a big part of what we're going to talk about today is obesity management, how it's changed over time. And in particular, talking about some of the peptides. So if we can really just start from the very beginning and explain what is a peptide.
So a peptide is pretty much just a protein that has some degree of functioning within the body, right? And they've always existed. It's not this something that just came out of the blue in the last 5 years. We've all had peptides for all of human evolution. The difference has really been in the explosion of a desire for weight loss and I think part of this country is also the high cost of GLP1s. But even a GLP1 is technically a peptide, right? It's essentially mimicking or endorsing the activity of the GLP receptor in order to help decrease appetite, increase satiety or fullness of the stomach. And so peptides really are just there to help some degree of functioning within the body, and each peptide has its own clinical significance. The issue has become is that when you're looking at evidence-based studies, you don't really see a whole lot of benefit when it comes to peptides compared to what we see with GLP-1. When I mean peptides, I'm not necessarily incorporating GLP-1s now because they're their own little thing and they've done remarkably well and they have been studied. They have shown, they have proven that they do cause weight loss and they do it safely. Whereas a lot of peptides really haven't really shown that necessarily. There may be some anecdotal evidence here or there, but there's not necessarily a whole lot of human studies that can confidently say, this is safe to use, this can contribute to weight loss or muscle building or quicker recovery or even delaying aging. There's a variety of them that we can get through later in the conversation today. But in short, a peptide is simply a protein that has some functioning within the body. GLP-1s, insulin, these are all peptides. But GLP-1 and insulin have shown benefit, whether if it's for diabetes when it comes to insulin, whether if it's for medical weight loss and other comorbidities when it comes to GLP-1s. But a lot of the other peptides that we keep hearing about in the media necessarily have not shown, and neither of their, or many of them actually even FDA approved. But we'll get to that here in a second.
Yeah. Yeah. As you're saying, some of these peptides have been around for a long time, right? We're very familiar with insulin, some other things on the market, but recently it feels like there's almost this explosion of other peptides that people are talking about. Mm-hmm. Where did that come from? How are these suddenly becoming popularized?
So a couple of different reasons. Number one, we now know more when it comes to medical knowledge than we did 2 decades ago, right? So obviously scientists have done numerous amounts of studies that have shown different particular peptides that can lead to different particular improvements or lack of improvements. Number two, even when it comes to formulations, right? Formulations of prescription drugs, we have also developed significantly in terms of being able to cross either the BBB, the blood-brain barrier, or even the digestive tract. So we've increased the ability of oral medications to be able to be absorbed better within the bloodstream. So that's number two. And number three, really just access to knowledge. With the internet, in the late 90s, and then now all of a sudden you have AI, but then you also have the advent of digital phones and everything. Now, I mean, knowledge really is just accessible anywhere. You could go into the middle of Africa with stable internet connection. You'll probably have the same amount of knowledge that somebody, living in Singapore or someone living in the United States may have. So these are the three reasons why we've seen an explosion really when it comes to peptides. The issue is there's something else called social media, which really is not really restricted well. And so you have all this information that gets put out there. And of course, there's also the need and the desire for a lot of people to lead healthier lives, but to also, lose weight. And the GLP-1s have shown tremendous stride in terms of doing that. I think I was reading an article just a couple hours ago. We've officially reversed the obesity rate in the United States. We went from 39% to 36%. Of course, and that correlates with an increase in the use of GLP-1s from 3% to 11% in 2024. 11% of the population now in the United States is on some form of a GLP-1 medication, which is quite a bit, if you ask me. Mm-hmm. But they have reversed the trend, and this is just the beginning. And that's why I say we're at the cusp of a revolution in obesity medication. But because access to GLP-1 is limited because of the cost, I feel like that's also a driver when it comes to peptides. People are trying to find a way to lose weight, to lead healthier lives, but they're doing it at a means of whatever becomes accessible or whatever they hear about or exposed to. And that's where social media, misinformation, and really a desperation to get healthier and lose weight really all comes into play. So that's the reason why peptides have just kind of exploded. The problem is there's only one or two that's really FDA approved. The only one that's FDA approved right now is tesamorelin, which even that is only approved for HIV-associated lipodystrophy, right? It's not approved for just regularly losing weight. There is sermorelin, which is actually approved in pediatric population for growth hormone deficiency, but even that that FDA approval has also been reversed. So right now, the only one that's actually FDA approved is the tesamorelin. Then you have a bunch of other ones. There's TB500, which is supposed to be, or thymosin K is what I think is the official term, that's actually used for muscle building. But again, no concrete, consistent human studies have shown that. Then there's also a CGKKU, which is utilized for skin rejuvenation. reverse aging skin. Again, no studies have shown that. And then there's also NAD+, which is not necessarily a peptide, but gets grouped in. I know this is going to kind of take people back a couple years, but remember in biochem, NAD+ and NADH are responsible for energy synthesis within the Krebs cycle, right? So NAD+ is technically supposed to be utilized for energy. It's utilized for energy metabolism, but we group it in with peptides because, again, we want to keep it simple. But NAD+ is supposed to be helpful with regaining energy. But then again, has it really been consistently shown? Not necessarily. But even if it has been, we already knew that from the beginning. This is what NAD+ is supposed to do. That's the function. So that's really the main ones that we look at when it comes to peptide. There's a few other ones that are here and there. One of the ones I think I was looking at was ipamorelin, which is similar to the other marelins. Again, it's supposed to be utilized for muscle building, weight loss. Once again, no human studies that have been done that have shown consistency. So this is kind of where we're at peptides. The problem is people can get these online. There's really no means of concretely trying to monitor their prescription. And the issue and the concern that we have is some of these can also be responsible for stimulating something called IGF, insulin growth factor, which actually can also be a tumor marker or a particular phase receptor within basically cancer-causing pathways. So that's the concern. We are doing this at the expense of trying to lose weight, but also at the expense of causing further damage down the road. And we need to be careful when we just throw these out into the market. And that's the concern I think that a lot of people have, a lot of clinicians, a lot of evidence-based supporting clinicians have. The only peptide I've ever prescribed was the semaglutide because we actually had an extensive workup that was done on a pediatric patient that was having the difficulty with obesity, and that was the only one. Otherwise, I've never prescribed any of the other peptides, but it doesn't hurt always to educate yourself on these, right? So that's kind of where we're looking. Out of
curiosity, in your clinic, are you seeing people giving themselves this? And if so, what do you do? Do you tell them to stop? How do you manage if they're like, absolutely, I'm not getting off?
Yeah, well, there's only so much we can do as clinicians, right? Our job is to tell them these are the adverse effects. This is the concern that we have, and this is what you're looking at down the road if you continue on this pathway. And then you do the best you can, and then you leave it to them at the end of the day. One of the big ones that has really come out, and we'll go over this here in a second, is retatrutide, or also known as GLP-3. And retatrutide is now available compounded, where people basically make this in their own little building or in their basement, and then they're selling it. And it's supposed to be very similar to the GLP-1s. It's actually better than the GLP-1s according to studies. And you can also get it from China, apparently. I found that out last week, where it's $150 per month supply, and then you inject yourself. I've already had a patient that finally confessed to me she went into the hospital because she overdosed on it. And I said, well, please don't do that again. If you want to, we can switch you to one of the FDA approved options right now, which we're more than happy to do, but she politely declined, and we said our goodbyes. So this is kind of the danger. And the problem is we as clinicians, the only thing we can do is tell them this is what should be done. This is why you shouldn't do it. And it's really up to them at the end of the day.
Do you know if there's any kind of like risk mitigation strategies? Like, are there labs that you can trend if they're going to keep staying on it, something to prevent the potential downsides?
The main ones I would really look at, and I mean, let's just take one of them, which is called TB500, thymosin beta 4. So that one is I think the bigger one that I'm really worried about is liver damage, right? That's the one that.
And this one is the muscle building one.
Yes.
Or the muscle recovery one. Okay.
And the way it's supposed to do that, it's supposed to cause angiogenesis, kind of like increased blood supply, right, to some degree. And so the one that I would be really worried about is a CBC, because I'm really worried about polycythemia, right, at the end of the day. And the other thing I would be worried about is liver damage, so a liver panel just to be safe and trend the liver enzymes, maybe not on a weekly basis, that's too much, but at least on a monthly or on every 90-day time frame. And so when you're looking at really monitoring, it really depends from peptide to peptide. One of the things that I also really worry about, and this is something that's a little bit difficult to monitor, really is ileus, right? That's something even GLP-1s have an issue with, the irreversibility of it to some degree. And how do you monitor that unless if you're having symptoms and you go into the ER and you get either a KUB or a CT scan? Those are really difficult to keep an eye on. And again, that is also one of the reasons why it's we should be really cautious when you're utilizing peptides, because monitoring is not cheap. So we're increasing healthcare costs, right? But second, monitoring is also difficult and it's tedious. And why would you want to continue, being in this negative feedback loop of increasing healthcare costs, all at the expense of wanting to do something that really isn't even FDA approved, and it really hasn't shown any consistency in terms of benefits. So that's a big question. And that's a question that we have to ask ourselves. Why are we allowing people to get away with this? And I leave that to our listeners, and also to, of course, any policymakers that are listening.
Yeah.
This is an issue. If our idea of a healthcare system is for prevention, that's great. I'm all up for it. But prevention should be done using evidence-based studies, using evidence that has shown consistent benefit, not at the expense of anecdotal evidence that really can't be applicable to the general population.
Yeah, it's an interesting ethical dilemma that I face a lot in the ER, because it's kind of similar or analogous to maybe the drug epidemic that we had. Like, people are going to do it. And I can see the argument of a clinician being like, you're doing this to yourself. I don't know how to manage this. We weren't trained in this. But then the flip side is patients are doing it, and it's still our responsibility to manage their health. And so it's tough. I really feel for the primary care docs out there that are trying to navigate this.
I find it very similar to, and I'm not trying to upset anyone, but when you've had the legalization of medical marijuana in Colorado, right? And then you saw the increase in marijuana-related ER visits, whether if that is, some degree of hyperemesis gravidarum or other issues. But that's what I really worry sometimes when it comes to GLP1s. What are we going to be looking at in terms of long-term ramifications? Anything that you put in your body, there's always a concern for adverse effect. But now the question is are we looking at, not just the cusp of a revolution of obesity medication, but also what are we going to be looking at downstream, maybe 15, 20 years from now? Will we be looking at persistent or chronic GI paralysis? Are we going to be looking at body dysmorphia, right? Sometimes enough is not enough, right? And that's something that's one of my big jobs, is to be honest and tell patients, okay, you've lost quite a bit. Now we need to start trending down. Now we need to start tapering you off of the GLP-1. And even there's really not, at least to my knowledge, a consistent schedule. And that really just depends on individual case by case on what and how we can taper someone off of GLP-1 when they have reached, or if they're closer to reaching their weight loss goals.
Is tapering a possibility once we get to close to weight loss goals, or even subsiding, or do we tend to see the weight come back without modification of other lifestyle interventions?
You're going to see the weight come back. If you don't have any modification of lifestyle events at the end of the day, you're going to see the weight come back. But that is the case of any weight loss drug out there. I tried phentermine many years ago, lost 40 pounds, then went through my intern year and gained most of it back, right? Because I came off of the phentermine, and intern year in residency is incredibly difficult. So you're going to see the weight gain back, right? Now, how much of that really depends on the individual, how much they're willing to adhere to lifestyle modification, how much are they monitoring in terms of their carb intake, their protein intake, their physical activity levels, the number of times that they're exercising or being active on a weekly basis. So there's a lot that comes into play. But yes, tapering is possible. And in typically, tapering is whatever is the lowest dose that you could utilize in order to maintain your weight. That's the way I would put it. The reason I say that is that's kind of like a one-size-fits-all rule. For some people that have genetic obesity issues, right? 2.5 milligrams of Zepbound may not be sufficient. Maybe it's a little bit more higher. But for someone that is only, looking to lose 15, 20 pounds, do they really even need to be off? Do they even need to be really on, a chronic GLP-1? And I wouldn't say so. I wouldn't think that's the case. That's someone that we could easily, teach how to, do behavior modification and how to be active and how to eat right. And you could definitely get off of it. But again, I think it also underscores what is really the future of healthcare, which is the consumerist kind of philosophy, but also the personalization of healthcare. Every individual to their individual scenario. And it is our job as clinicians to tailor to their needs and to come up with individualized plans. And I think that's a good thing, because it means we're actually giving each individual patient more care. But it also means it's a little more work on the clinician, because we have to adhere to all these guidelines, but also come up with millions of different plans for each of our patients.
Yeah, and I think that's such an important piece of it, right? When we start a medication, a lot of times on our end, we think about, okay, well, what is the lifespan of this medication, right? Is this something where we're treating either something more acute, or we feel like there is an area where we're going to be able to get off, or is this something, almost more similar to a statin? We're probably going to, for a lot of people on it for the long term. And it seems like there's going to be a combination.
Yeah.
There's probably people that are going to, once they start it, should probably think about the idea that they may be continuing on it for a pretty long time if lifestyle modifications and if other interventions are not desired or, possible for that individual or, kind of in the cards for them. Whereas other people think about it more as a short-term tool where tapering down on the dose or even, stopping after some amount of time alongside other interventions is a possibility.
No, definitely. And I think it's really interesting how GLP-1s have really changed even like the healthcare business model, right? Because one of the things that we're noticing, at least here in Oklahoma and also a little bit in Arkansas, is bariatric surgery, or at least a reduction or for the need of bariatric surgery. And what that means is people who were specialized in bariatric surgery are now expected to possibly be open to performing other general surgeries, which most of them are already trained. So, that's not a concern. But that business model now, it has become almost, very obsolete really quickly, because what is the need of bariatric surgery when you can put someone on Zepbound and you could help them lose 200 pounds over the course of 2 years? And you also don't necessarily have the post-surgical complications. So it's really fascinating how we're seeing this happen literally in front of our eyes. And we're not talking 5 years, we're talking 1 to 2 years of a change, of a transformation in the way the business of healthcare is conducted. And that is fascinating, but it's also a little bit frightening as what else we're going to see in the future.
Yeah, we've seen this in medicine so many times, right? Where there's an advent of something and then an entire procedure or, some kind of intervention is no longer the gold standard anymore. It's no longer the norm. And that is just a function of medicine. We should always be improving. We should always be trying to find the next thing that is better for the patients, that's safer for the patients, that's more effective, or some combination of the above. And it is a really interesting time to navigate that, right? I mean, we can even talk about like the AI integration into medicine, right? That's going to change the scope of medicine in a lot of ways. And if it makes patient safety better, right? If it makes, things more streamlined, if it makes it faster, then, I'm all for it. If something is going to make the patient experience better, if something's going to keep them safer, then we absolutely should be doing those things. And I think it just makes us better. It helps us morph into a more effective clinician. And so, but it's wild to see how quickly something like that can change.
Well, one of the things I wanted to ask you guys is what have you guys seen when it comes to utilization of GLP-1s?
Yeah, I mean, Dispo has seen more than me.
Yeah, I mean, one of the most profound things that I've seen actually is just this sudden drop off in DKA presentations to the ER.
Huh?
It's wild.
Wow.
I can think of in like one hand the number of DKAs I've treated in the last year compared to like before it was like once a week at least. I think it's making a huge change, but then the complications are also kind of interesting, not that dramatic as I would have expected given how many patients are on it. But one of the intractable vomiting, of course, is the common one we see.
Yep. No, it's really it's going to be a really interesting time to see what happens in the next 5 years, especially as we have retatrutide, or what's called GLP-3, because it's actually three a weight loss medication is GLP-1, GIP, and glucagon receptor. It'll be really nice to see once that's approved. And then you also have cagrisema, which is a combo of a GLP-1 and then an amylin analog. Amylin is very similar to incretins. They do decrease appetite to some degree, but cagrisema is also supposed to be very similar to or close to what retatrutide has shown. So it'll be really interesting to see once those two are approved, because they're supposed to be better than what we have on the market. And that's just kind of mind-boggling already to think of how that's going to be. And especially retatrutide, because the glucagon receptor is supposed to help prevent muscle wasting. And that's a big deal, because for every 4 pounds of fat that you lose, you also lose 1 pound of muscle. And so that is going to be really cool to see how people on it, how they're responding initially, but also how much muscle are they retaining. And, and of course, we could talk about the body composition scales and DEXA scan follow-ups just to kind of monitor it. But that'd be a really cool study to do, people on retatrutide, just to kind of see how much muscle they're actually maintaining as they're losing tremendous amount of weight.
I was seeing, though, actually more recently that a lot of that initial studies on Ozempic causing a lot of muscle loss doesn't seem to play out with the newer ones like tirzepatide and the I forget the name of the one, the R one,
Yeah, the
which I
retatrutide.
thought which I thought was interesting. So I'm wondering if it's like it was a unique to Ozempic thing, or maybe the studies were overplayed, or maybe we've just like started to understand how important muscle building and exercise is while being on these medications.
I think it was really an evolution of understanding how important increasing protein intake and muscle building is while you're on GLP-1s, but also remember semaglutide or Ozempic Wegovy is just a GLP-1, whereas tirzepatide or Mounjaro Zepbound, those are the other two names for it, is actually GLP-1 and a GIP agonist. And the retatrutide, like I said earlier, is GLP-1, GIP, and glucagon. So I think as you combine, different receptors, I think there is some benefit, specifically when it comes to maybe some degree of preventing muscle wasting, specifically with the retatrutide, just because of the addition of the glucagon receptor. But the semaglutide has also been, one of the earlier ones. And of course, as we continue to build and you continue to investigate and research and trial and error, you tend to have better products eventually, right? And I think, probably here in about a year or two, semaglutide might just not be, I think it'll still be utilized, but it'll become much more affordable because it is no longer really going to be able to compete with some of these newer options. And that's actually a good thing. That's a good thing for patients who are looking at, at leading healthier lives, at losing weight. But we'll see. That's going to be another thing to look into, is just pricing, how pricing dynamics change when you have the advent of newer weight loss medications.
Have you noticed anything about any of your patients on long-term GLP-1s, anything about this increase in resting heart rate that these seem to be causing?
I have not yet. But I'm also wouldn't necessarily be surprised. There is some degree of, our semaglutide is Wegovy, or the Wegovy version of semaglutide is already approved for reducing cardiovascular mortality. And there's also trials being done for tirzepatide. And I'm not surprised at that, though. I haven't seen it myself in my clinic, but I also don't necessarily find that surprising, given that we do know that the GLP-1s receptors do seem to play some degree of a beneficial role, probably in cardiovascular health. But
actually, maybe we're talking about something different. I think they're increasing resting heart rate. They're not decreasing. They're actually increasing it, which I thought is odd, given that they are supposed to.
I have seen that. And my theory is, and this is just a theory, I haven't had the time to do like a full randomized control trial about this, but I think the theory that I have is a lot of it has to do to some degree with dehydration, with not really hydrating yourself properly. So when you're reducing your appetite and you're trying to lose weight, that doesn't mean, no one's telling you to starve yourself, right? No person should really ever be below that 1,500 calorie diet. But my theory is, I think a lot of it has to do with not properly hydrating yourself, not properly not having proper oral intake. And so when you have, this dehydration status, then you have tachycardia, the body automatically develops it to compensate. But I think that is the theory that I have. Now, I haven't necessarily seen lower heart rate or bradycardia yet, but I have seen tachycardia. But it also doesn't surprise me. This is also, although semaglutide is also approved for CKD stage 3 and worse in diabetic patients, it is also known in some cases to cause AKI, especially within the first couple of weeks. It is something that I urge all my patients to monitor, but I also tell them, this is the amount of water you're supposed to be drinking on a day-to-day basis. This is the amount of protein I want you taking in based on your weight. And this is the amount of carb, certain grams of a percentage of your diet has to be carbs, just in case, because we don't necessarily want you to get hypoglycemic also, right? Although I will say this, I have only seen, out of probably 1,000 that I have done with GLP-1s, I've only ever seen one case of hypoglycemia with GLP-1s. I have not yet seen more than one. And I find that to be impressive, especially given, you were talking about how you have seen a reduction in DKA cases, which I think is really, really cool. And that's a really cool aspect of GLP-1s. But I have not really seen that much hypoglycemia. I think I've seen more hypoglycemia associated with sulfonylureas, the glipizide, glimiprides, than I actually have of GLP-1s.
Yeah, that's so interesting. So we kind of covered the difference between the GLP-1 medications and then the dual agonists with the GIPs as well. And then we talked about the triple agonists as well. But just to kind of wrap that part up, can you talk about or explain a little bit more why the researchers are adding the glucagon receptor activity to some of the more investigational drugs?
Yeah, I really think it comes down to what else could be done to improve.
Yeah.
And again, what could be done to set us apart? And that's kind of a selfishness from the pharmaceutical companies. What I mean by that is, what could we do to put on the market that could cause, greater weight loss, but also could reduce some of the adverse effects, whether that is muscle wasting, whether that is more GI issues. And I really think that's where it comes down to play. It really is what's the next one? How far we can go? There's one, I'm kind of blanking out on the name on it, but there is a theoretical one that is actually supposed to be against ghrelin. It's a monoclonal antibody that is supposed to be against the hunger hormone ghrelin. And that is just mind blowing. I know I'm kind of nerding out right now, but for those of you that don't know, ghrelin is the appetite hormone. This is also stimulated when you're hungry, but also when you a lot of people get mad when they're plateauing. But the reason people plateau is because when you lose a certain amount of weight, your body starts believing that it's crashing. So then it actually increases the production of ghrelin. And this is why people plateau, because the body is wanting to save off itself, because it's interpreting weight loss as a means of, of dying. And so it counteracts that with increasing ghrelin hormone secretion, which is really cool. But that also causes the plateauing of weight for a lot of people. But now we're developing a whole different way of of the body not even producing that, which I think is really cool, because that is really one of the mainstays issues that we tend to see even with GLP1s. People are on a dose for a certain amount of time, then they plateau, and then it really falls upon us to say, okay, why don't we either increase your protein intake or increase, the ability for you to spend a little more time in the gym, focus more on muscle building, or the other option would be is increasing your dose, right? And so when people are plateauing on GLP-1s, that kind of gives us a message that we're going to have to do either an increase in activity level, an increase in better nutrition, or an increase in dose. But with this monoclonal antibody, who knows what we're going to see? I mean, you could just basically stay on one dose probably with it, and then just continuously have continuous weight loss, which I think is crazy. But again, to answer your question in short terms, it is simply just a human nature. What can we do to make it better? What can we do to outdo our competitors? And what's the largest number that we could really get to in terms of weight loss?
This just seems so wild. I mean, GLP-1s in general are already what feels like such a new class of medications, a new era of medicine. And we have seen, muscle loss and issues related to that, even just in the short amount of time that these have been, pretty ubiquitously utilized. And we're already coming out with things to mitigate some of the adverse events from these peptides. And it's so interesting that this feels like it's moving really fast. I feel like we haven't seen this so much in other aspects of medicine or therapeutics. It's just wild how quickly we're able to add other receptor agonists on there and create these new compounds. And it's wild how quickly I feel like this area is moving.
Yeah, we really haven't seen this I guess we've seen it when it comes to oncology, right? We keep seeing rapid development of neuromedications, but nothing as revolutionary as GLP-1s when it comes to obesity. We've seen recently Baxfendy, which was released, which is, a blood pressure medicine. It is supposed to be an aldosterone blocker, and they're recommending it for any patient with uncontrolled hypertension that are on 2 or more medications. And then that's really it. Like when it comes to hypertension, when it comes to antibiotics, even mental health, we keep seeing here and there newer drugs for mental health that are approved, but we haven't seen something at this level. Although, and I hate going back to GLP-1s, there is studies that are being done and utilizing GLP-1s for schizophrenia, for alcoholism, and even in some cases for Alzheimer's dementia, which that is also that would be really fascinating to see if GLP-1s ever really do get approved for Alzheimer's, because that goes into this theory of Alzheimer's dementia really being a form of diabetes, type 3 diabetes, because there is some degree of consistency when it comes to insulin resistance in Alzheimer's versus type 2 diabetes, which is a very similar path of biz. And of course, type 2 diabetics have, I think, a 50% increased chance of developing Alzheimer's. But the problem with that whole theory of labeling Alzheimer's as type 3 diabetes is that Alzheimer's also has other causes, including the ApoE4 alleles and vascular dementia and all that stuff. But that's for a whole different episode. But it's really going to be cool to see where GLP-1s, if they could also be utilized on the mental health side, that would be something really cool too.
Yeah, this is so fascinating. And I mean, as neuroradiology, right, I see tons of neurocognitive conditions and neurodegenerative disorders, Alzheimer's, absolutely. And so this is so fascinating.
Mhm.
And it's interesting to see what other effects it potentially could have, because then I think we kind of also ask this other question of who else should be taking these. We have this population of patients right now that are utilizing this for weight loss, and we're seeing metabolic effects, and it's really hard to argue against the benefit of that. Even with some of the muscle adverse effects in relation, but like, is there a role for other people and just the general population, even if there aren't weight loss specific related requirements? Who else could be taking this and could get some benefit out of it?
I mean, obviously, we talked about type 2 diabetics, right? And of course, people that are interested in weight loss. One of the subset of populations that I have not officially ever used, but I've recommended it looking at is patients with autoimmune disorders. Specifically, there's being some studies done where GLP-1s can reduce inflammation. That is a population also to keep an eye on. And then, the other ones that I think would be really cool, and I haven't utilized it again here, is alcoholism. Because in theory, if you're reducing your appetite, you're technically reducing a craving. So that should also apply to a craving for alcohol, right? So this is all theoretical, but there are some degrees of studies I think that are being done to look at that, look at GLP-1 utilization in alcoholics, and I think that would be another population to look at. So patients with autoimmune disorders, patients with history of alcoholism, those are the two that I think would be really cool to look at. Just based on some of the research that we have seen, and also the benefits that I have seen on an anecdotal evidence, where I have patients that have comorbidities, usually type 2 diabetes, plus or minus, RA, lupus, and then all of a sudden we get them on GLP-1, and one of the first things they tell me is, I just feel much better because I'm not in that much discomfort. And I'm like, oh, okay, well, that's great. That's good to know. Well, that gives us more of a reason, although there's really no approved indication for autoimmune disorders yet when it comes to GLP-1s. Just have to throw that out there then.
Yeah,
I'm
I
actually fascinated by this connection between alcohol and GLP-1s, because it really speaks to this idea that like addiction and food and obesity are so similar, and we just haven't appreciated that until recently.
We really haven't, and I think that is really where we kind of have to look at. I think if we want to continue to have improvement when it comes to obesity reduction, because this isn't, obesity is very complex, right? It is a chronic illness, but there's so much to it. It's not just a matter of, this is the gene that you have, therefore, X, Y, and Z. It's a matter of genetics plus or minus behavioral decisions or lack of behavioral modification, plus or minus some degree of the epigenetic world. There's so much that really comes into play. And I think now we're sort of on the right track in terms of trying to understand what obesity is and trying to reduce the stigma, but we still have a long way to go. I don't want to jinx ourselves. We still got a long way.
That was actually going to be my comment. I wonder what other areas of addiction psychology, right, could this play a role in addiction medicine outside of even alcoholism? And it seems like there's a potential promising link there. So I think that's going to be really fascinating. But what other evidence do we know is emerging in terms of cardiovascular and like renal health?
So renally, when it comes to GLP-1s, we already have an indication for it, CKD stage 3 and only diabetic patients. It cannot be a non-diabetic. And I think the idea behind that is, of course, obesity is tied to increase in hypertension. Obesity can also be tied to in worsening cardiovascular status. And so everything is connected at the end of the day. So clearly we've seen some benefit when it comes to renal protection, GLP-1s. With the cardiovascular benefit, I think it really just comes into play. You're basically looking at reduction in obesity can lead to reduction in hypertension, reduction in dyslipidemia, reduction in fatty liver disease, and so on and so on. And when you look at all these other, benefits, and then eventually you also end up getting, with all those modifications and improvements, you also end up getting reduction in cardiovascular mortality. So that's really where the cardiovascular assistance from GLP-1s really comes into play. Zepbound or tirzepatide right now isn't necessarily approved, but I think that's the next indication I see really coming up, because there have already been, I think it's called the Surmount trial. Don't quote me on it, but I get all my trials mixed because there's just so many new medications that keep coming out. But that would be something I think that would be really to keep an eye on, and I think that actually that indication probably will be here within the next year, is my opinion.
So for those of us who are not seeing patients on these medications on a daily basis, can you give us a little bit of a ballpark of what numbers we're talking about when it comes to, we can start with like cardiovascular benefit, right? If we're talking about blood pressure reduction, if we're talking about lipid metabolism or lipid levels going down over time. How big of a difference are you seeing on these medications?
So, I mean, it really depends on what the starting point is, right? If you have someone that is 450 pounds versus someone that is 200 something with a BMI of 60 versus BMI of 30, obviously that's going to be a little bit difficult to compare. But what we have seen is we have seen a reduction in LDL and an increase in HDL, specifically below 100 on the LDL part. And then when it comes to blood pressure, I like doing it by stages. So, typically from hypertensive stage, usually 2, we tend to see them dropping at least below stage 1 to kind of the pre-hypertensive stage. And that's usually over the course of 6 months. I think you may have even more quicker improvement. And that is something we warn all of our patients of. Hey, like if you're on hypertension medication, please keep an eye on your blood pressure, because as you continue to lose weight, your blood pressure will start improving, and we will start having to look at tapering you off of blood pressure medication. We have had that happen numerous times where patients come back to me after 60 or 90 days and they tell me, hey, I'm getting dizzy. I'm on hydrochlorothiazide and lisinopril, and I'm not sure why. Well, I know why. Well, it's because your blood pressure now is much better controlled because you've lost 25, 30 pounds over the course of the last 90 days. And this is good. This is what we expected. But it also means it's my job now to keep an eye on your blood pressure. So we're going to probably have to taper you off of one of those 2 blood pressure medications, which is what we want to see, right? Before GLP1s, I don't really remember if we ever saw someone or let me take that back. I don't remember how many times we saw people where we've had to taper them off of blood pressure medications, because of weight loss. But I can tell you definitely that aspect has become more pronounced now that we've actually have GLP-1s causing significant improvement in weight. You are looking at iatrogenic hypertension being a major issue, and that's a good thing. That means that we are able to track it. We're able to catch it early as long as we educate the patients and we're able to get them off of medication, which is really what we want to do, right? That's actually what we want to do. We want to get people off of with blood pressure medicine or cholesterol medication or diabetic medication, right? That's what we want to do. And that's really what the GLP-1s are helping us do. I actually have many of my patients that initially were on insulin, and eventually after, a certain amount of time, we thankfully get them off of insulin. And then eventually it's a matter of getting them off of their diabetic drugs and their hypertensive drugs and the lipid agents slowly, one by one by one. The lipid one is something that I'm a little bit more cautious about, mostly because if you are a type 2 diabetic and it's above a certain age, there is a recommendation to be on a statin. And although insurance companies don't see it this way, I've always felt that once you're a diabetic, you're always a diabetic, right? Because there's always a propensity for your A1C to worsen quickly. So the lipid agent is something that I always am a little bit cautious. But when it comes to blood pressure medication and other non-GLP-1 related diabetic medication, I think that's not that big of a concern to monitor or even to modify, because the GLP-1s do a pretty good job of keeping the glycemic index under control, but also continuing with weight loss and thereby better blood pressure control.
Yeah, interesting. Are there certain patients where you don't see blood pressure budge as much? And this is like totally theoretical here, but I mean, so in some patients with higher blood pressure, there's multiple, ways where people can get high blood pressure, but one is with hyaline deposition, right? And so there's arterialization of the blood vessels, and they can become more stiff. Then we get increased blood pressure.
We typically tend to see the need to titrate on blood pressure medication in patients between the ages of 40 and 65. And then as you get older, there seems to be less of a hypertension concern. And I think it kind of goes to what you're talking about with the stiffness of the blood vessels. As we all get older, you have more vasoconstriction. And and all the stuff when it comes to the blood vessels. And so we haven't really seen a whole lot of that in patients above the age of 70, and especially as they get older. Now, with that said, I'm also a little bit cautious about utilizing GLP-1s in anyone above the age of 70. So we have a few, but we've also are not too inclined to necessarily utilize GLP-1s unless if there is a huge morbid obesity concern, or if there is a very difficult glycemic index control concern. Like if we've tried Jardians or Januvia and nothing seems to be working, okay, well, why don't we try a GLP-1? These are the things we want you to be worried about. Mostly the thing I worried about in patients above the age of 70 is GI issues, and specifically small bowel obstruction or ileus, which we haven't seen, to be upfront and honest. I haven't seen any of that in my patients, but that's also because in our clinic, we also practice the philosophy, you go low and you go slow, right? No one's going to start you at the highest dose and expect you to do well. That's not going to happen. You're going to have some degree of side effects. So I think in the older population is where you tend to see less and less of an improvement in blood pressure issues. Whereas in that age 40 to ages 65, that's when you really tend to see a lot more benefit. But that's also the population that we really need to be targeting if we're looking at, improving the healthcare status of the United States as general, because we have shown constantly, studies have shown consistently that prevention is not just a benefit, but also a benefit economically, because it does lead to lesser comorbidities as you have an aging population.
Yeah, that's interesting. And the ileus you were mentioning, we think that potentially is irreversible to an extent.
That's a really good question. Wow. I don't necessarily think it's irreversible, but I also think it's dependent on dosing. And I also think it's dependent on an individual case by case scenario. What I mean by that is if you have someone on the highest dose possible over the course of a decade, right? I think you have more likely of having some degree of ileus compared to someone that's on the lowest dose possible. And that's obvious. The dose dependency is there, right? The higher the dose you're on, the more likely you to have side effects. That's just the nature of pharmacology. And I think that applies also here to GLP-1. So if you are actually on a higher dose for a longer time, I don't necessarily think it's reversible. I think the issue is you have you're more prone to having long-term complications compared to someone that's on a lower dose. But that's why, there's some theory that maintenance should always be the lowest dose, which is, 2.5 for tirzepatide or 0.25 for semaglutide. But then there's also a theory that it's really, again, case by case, individualized. It's the lowest dose that is necessary for weight maintenance.
Yeah, and this is, total theory again, but if we start seeing ileus become more ubiquitous with this utilization, that makes me wonder if there is a potential downstream dysbiosis factor that could come into play. And as we're learning more and more about so many other areas of medicine, we're also learning more and more about the microbiome and the numerous downstream effects that we're understanding more about when it comes to gut dysbiosis and, issues there. So I wonder if that's a potential, longer term implication of utilizing these medications.
I will say anecdotally, which is not good. Anecdotally,
this was total theory. So, I'm not even saying that, could happen.
I see plenty of people coming in the early stage, and we tend to, I'm an ER doc. I scan everyone. Functionally, the people that I do end up scanning, I've never had an actual bowel obstruction, like a true small bowel obstruction from any of the GLP-1s. And ileus is like equally, I've pretty much never seen. It's usually that their intractable nausea vomiting is from gastroparesis in the early stages when they just don't know that they shouldn't eat that much. And then as they're on it for much longer, they start to learn what quantity they can put in. And then it seems to go away, actually. So I actually have not seen any long-term, again, anecdotal.
And that's good. That even if it's anecdotal, that's good, because that's what we really want to see, right? We want to have the best of both worlds. We want to be able to have the most effective in terms of national obesity rate reduction, but also not have to worry about any of these other long-term applications, because that is something I think we have, not just GLP-1s, but anything that we look at and any medication or any class of medicines. What are the long-term applications? And I think that's something that's been missing when we were all looking at opioids, right? In the 90s and early 2000s, people were prescribing them, and that's a whole different story for a different day. It really has to do with a complex case of pain being added to the patient satisfaction index and more pressure being placed on physicians to prescribe these, and so on and so on. And look where that got us into. My worry with any medication class is, what can we do to avoid that from happening? Right. That is one of our responsibilities as clinicians, is to make sure we don't look at something that's a detrimental long-term sequelae of anything that we're prescribing.
Yeah. Where do you think obesity medicine is going to be in like 10 years?
Wow, that's 10 years is a long way to look into the future, really, at this point, just how fast things are moving. I think in 10 years, I think our goal would be, while simultaneously trying to continue to decrease the current rate of obesity, I think what we would be looking at is even preventing it. And I think that's really going to be the next big step, the next giant step, which is, how do we start looking at it from a pediatric age and preventing obesity from even occurring? And there's already been some some development of, I think Pfizer was the one that was looking at, and I can't think of the exact the drug number name, but there was some study of looking at utilizing, I think it was a hormone of some type, to help prevent the development of obesity like in adolescent age. And I really think that's where obesity medicine is going to be headed. I think you'll still have newer drugs coming up, but I also think you're probably going to see better oral formulations, and that is key to reducing cost, right? One of the reasons why Eli Lilly came up with the Quickie pen, where you have one pen that you can use for 4 doses, was to reduce costs compared to the automatic injector, which was a weekly pen per each dose. With the Quickie pen, you can basically just do one pen for essentially for 4 months, 4 weeks is what I've heard. And the idea behind that is reduction in cost. And oral medications probably in 10 years will become more of a mainstay than they are right now. Right now, the only oral options we have are Fondayo, which is from Eli Lilly, and then the Wegovy tablet, which is from Novo. So those are the only 2 oral formulations. But I think in 10 years, you're going to see more. And I think you're eventually going to see less of a reliance on the injectables or subcutaneous utilization. And that is also important because that shows us just how much we have been able to develop when it comes to formulation of medications, but also that we're trying to keep an eye on cost containment. And that is key to, to preserving, our healthcare system from going bankrupt. So I really think in 10 years, an emphasis on preventing obesity will definitely start. We'll definitely start looking at it, but we're also going to see probably less and less utilization of a subcutaneous route and more of utilization on the oral.
Yeah, that's actually a huge topic. Thanks for bringing that up. That we didn't really cover the oral versus the injectables, the subcutaneous utilization. Not as common of a method today, but potentially something that hopefully we'll gain more understanding of and be able to create more of down the line.
Well, I mean, the oral ones are not comparable to the injectables yet, but down the road, I think you'll definitely see better results with oral GLP1s. But I think we're still probably a couple years away.
Awesome. It's backtracking just kind of a little bit, but for physicians that are really just kind of getting into the space, really trying to explore peptides and understand them, is there anything else that you want them to understand about this sort of newer area of medicine since it's exploding so quickly?
I think my only advice is continue to learn, continue to grow. That's really, the key to really meeting the challenges that everything is kind of thrown at clinicians, whether if that is the advent and the rise of misinformation, the rise of utilizing social media, not just to reach out to patients, but also advocating for patient safety and advocating for health equity. But I really think it's really just an individual scenario of, if this is something that you're passionate about, put the time, put the effort. There's really no shortcut. I really don't have one resource that I can really relay patients to. A lot of my studying has been a mixture of up to date versus whatever I could find on the internet versus really just anecdotal evidence that I hear from all my other colleagues that are kind of in the med spa business, to be honest with you. And the reason I did that is to kind of understand how they're utilizing them, because they see this on a day-to-day basis and they're able to do it without the confinements of a healthcare system or the legal confinements of a healthcare system. So at the end of the day, this is something that you're really interested about. This is something you're really passionate about. You have to put the time. You have to put the effort. There's no shortcut. Continue educating yourself, continue growing, and continue just meeting the challenges that lie ahead.
Awesome. And then another kind of question that I had that we didn't fully get into, we're talking about compounds that people are utilizing oftentimes that are not prescription based or not even FDA approved. And because this is so new, I'm kind of equating this with something else that I'm familiar with, which is supplements, right? And almost similar issues there being that 2 products may not be equivalent, right? When we talk about the supplement industry, we talk about almost the wild, wild west of what could potentially be in that product. And we've seen issues with there either being less or more of what was indicated of the product in the supplement, and then plus or minus, who knows what else in it. And so I think we've gone a long way in the supplement world. There's a lot more third-party testing now. There's certain sites that, are doing things a little bit better, but there's still a whole bunch of products on the market that really aren't being regulated. How do peptides relate to that and kind of fall under a similar category?
I think they fall really under a very similar category. When you're looking at compounding, GLP-1 compounding has become a major issue, right? And that's why the FDA theoretically is trying to play more of an active role in preventing that. Now, there's more to that story. There's more of a collaboration that's being done by Eli Lilly and Novo to really to cover their profits. And I understand that. And then they do have the patent rights. I get that part. But I think peptides really fall very similar to compounded products. And a lot of peptides are actually compounded to some degree. And so there's not really much of a difference when it comes to, I mean, there's difference when it comes to the benefits of individual peptides, but in the long abstract view, they're kind of being utilized by the same people, right? People that are trying to get their hands on some ways of getting healthy, of losing weight, simply because they can't afford the prescription versions. And one of the reasons why Eli Lilly and Novo came up with their own online pharmacies with Lilly Direct for Eli Lilly and NovoCare for Novo Nordisk is simply because of compounding. And that's where I have to give the compound pharmacies their due. They have literally forced these pharmaceutical companies to reduce price so they won't necessarily be losing that aspect of business sales to compounding. And, I give them and I applaud them for that. With that said, I think you have to be really careful. One of the things, that's always concerning with compounding is safety. It's really dependent on who the compounder is and what their quality is and what their intentions are. We have seen, and I've already given you guys some examples of people using GLP-3 from China and overdosing. We have already seen quite a bit of those stories from local compounders, if that's in Oklahoma or Texas. I've used compound pharmacies, but in scenarios where, and I can give you a scenario where I have a patient that does not have the greatest insurance, that doesn't necessarily meet criteria for type 2 diabetes or sleep apnea, that BMI is 40 plus, and they're not diabetic yet. They don't have any history of heart attack or strokes, and they don't have history of any proven history of MASH, metabolic associated steatohepatitis, or fatty liver disease. So what do I do? We know that obesity is a very challenging aspect of an individual's health and that it's tied to a lot of different other chronic comorbidities. I have a responsibility to help treat the obesity, but I also can't necessarily do that through the insurance way. And this is a patient that can financially afford compounding. What am I going to do? I'd rather do something than nothing, right? That's just the way that I've always worked. And I think I look at the patient's overall interest in terms of their overall healthcare. And so in those cases, yes, we have used compounding, but it's not something that we prefer to do. It's only in cases where there's really no other way to do it, right? And that's the issue. And that also is a perfect example of what's really wrong with the American healthcare system. To receive help, medicated help, you have to be truly, really sick. And I don't think that necessarily is a good thing, because prevention helps prevent chronic healthcare management. It helps reduce these chronic healthcare costs. And we're not there yet in the United States when it comes to GLP-1s and, of course, many other medications and services. And that's really sad. That really is. I think one of the things that I will say here is there is always going to be a place for bariatric surgery, whether people want to accept that or not. I do agree that the GLP-1s have revolutionized healthcare when it comes to bariatric care, but you're always going to have a need for it. Now, the healthcare economics, how that works on an operations level for running a full bariatric surgery practice, that's a whole different story and a whole different podcast. But you're always going to have a need for bariatric surgery. But at the same time, our healthcare system really right now, despite all the talk, all the political points and everything that we make, we are not a healthcare system that emphasizes prevention. And the lack of coverage or the lack of access to GLP-1s is a key indicator of that.
Yeah. If people are interested in pursuing these, maybe falling into a similar population group where, they don't meet indication or criteria, is there anything that we can tell them or tell physicians to help navigate these compounding pharmacies?
Mm-hmm.
And now I guess when it comes to supplements, at least I can tell people look for third-party testing, look for more reputable brands. Things like Fullscript, are also doing a lot of that, which could be beneficial. So getting it either direct from source or a place like Fullscript as opposed to, just a generic place to get them. Is there anything like that we can help tell people to navigate?
I think the only thing I could tell people is to do their own research. But the way I would do it is just try to see how these compound pharmacies are mixing their products and where they're getting their ingredients from. And that really can be a key. There's some, I'm not going to mention names. There's some pharmacies that try to get their basic ingredients from the same places where these larger pharmaceutical companies do. And then there's some that just, again, I'm not going to mention names, that's just sort of just mix and mash. And then, they add a little bit of B12. And I can't really indicate if that necessarily is for benefit, or if that's to get away from the FDA saying, hey, we have our own product with B12 formulation. or mixture into a formulation. So I really think that the best way to do it is to research an individual compound pharmacy, see where they're getting ingredients from, see what safety protocols they're taking. Is it being mixed sterilely or not? And then the other thing is what is their price range, right? For a while, that was one of the bigger concerns I think that a lot of people had, which was some of these compound pharmacies were just making money left and right, and they were really just being, a cash grab at the end of the day, and that's sad because they're really just playing on people's, desire to lose weight, and they were just making money off of it, and that really shouldn't be the case when it comes to healthcare. But to long story short, investigate each compound pharmacy, try to figure out what and where they're getting their ingredients from, and what kind of safety protocols are they following.
Awesome. Thanks. What else did we not talk about that you wanted to address today? I know we covered a ton.
Man, I was just curious, how'd you guys come up with this podcast? Because your podcast is really interesting. Because when I came along and I was like, oh, this is really cool. Because it's like a mixture of different things. You're not only are you guys looking at nutrition, but you're also looking at medication and then a bunch of other stuff. So how did you guys come up with this?
Yeah, that's a fun backstory. So we both did the lifestyle medicine certification together. Divya's emergency medicine. I'm neuroradiology. We both, as we started off talking about, see a lot of the chronic diseases, right? And just trying to figure out, well, what can we do differently? What can we learn about prevention? And a lot of it came from our own health and our own interests. Divya and I, we've been friends since med school. And I think we're both just incredibly nerdy and love learning how to learn. And so we went to med school, we went to residency, we learned a ton. And then now we just both wanted to keep going. And so this is like how we would hang out. We would talk about sleep medicine and learn about sleep architecture. We would talk about basically anything related to health. And then I started Dive Health MD looking at food. I was with some my own GI issues. That's partially how I got interested in it. And I started spending a lot of time with farmers and learned that, man, not all food on the market is equivalent. And so when we talk about chicken even, right, like 2 chicken products on the market can be vastly different in terms of their nutritional composition and profile. And that is just true of every single ingredient. And so what I was finding is we're having a lot of conversations about what to eat. Should I eat a plant-based diet? Should I eat a carnivore diet? Should I eat, vegetables or fish today for dinner? But I just kind of thought there was so much more behind that in terms of, well, what's the quality of the options that you have? How do we find quality food ingredients? Because not everything, again, out the same. And so I got interested and then started creating a docuseries. And so the docuseries I'm making. And so I'm still doing a ton of interviews. And there was a point where I had these incredible conversations with farmers, people in the food production industry, nutritionists. I mean, some really, really incredible people. And I was kind of holding on to it as I'm working on building each of the episodes. And so I sort of decided one day, well, let's just release it as a podcast episode so people can start learning about food. And so I think one of the first ones was an interview with James Arthur Smith. He's the CEO of a company called Seatopia, and they do regenerative aquaculture, seafood. And incredible company, incredible story. And I was just so excited to, put their story out there. But kind of simultaneously, Divya and I were just interested in all things related to health. And, it's an interesting part of medicine where I don't get a whole lot of chance to talk to a lot of subspecialists. I don't talk to a lot of primary care physicians. I talk to the ED the most, but I'm pretty much saying positive or negative stroke, there's an aneurysm here, and, talk to you later. And so I just really like the idea of being able to understand where medicine is today, where medicine's going. I love talking to other subspecialists. And so that's where it came from. So the podcast is a combination. Every other episode is a farmer or something about food. And then the other episodes are people or physicians. And the concept is prevention. So we're talking about what physicians are seeing in practice and what we think we can do to mitigate any of that. Mm-hmm. And it's been really fun. One of the first ones that we did was with our other friend from med school. And funnily enough, we had just spent like a week together. He's a pain doc. And we had a whole conversation about back pain. I read it as a neuroradiologist. Livia sees it in the ER. And then Neil treats it as, a pain management physician. And we had never had this conversation in person. Yeah. And it was fascinating. And it was so interesting to get his perspective on back pain. And so it's just been part of the fun. We get to have a whole lot of conversations that we probably wouldn't have otherwise.
Well, thank you guys for what you do. And, one of the things that I'm really trying to get better at is trying to incorporate nutrition more and more. into not just like my obesity practice, but like in primary care in general. And of
Mhm.
course, I mean, we always say, watch your salt intake, a little bit of cinnamon for, we all do that. Like, but I'd like to get more in depth into it. So that's why I just found your podcast really, really interesting. And then when it comes to like, protein diets, I've kind of looked a little bit into plant-based diets and to paleo diets. And of course, the one that always scares me when they're doing the all carnivore diet, and I'm worried about, LDL immediately and all that. So
Yeah.
what would you recommend for someone that is looking at losing weight and is looking at maintaining at least, like a healthy weight? What kind of diet would you guys recommend?
So it's such an interesting question.
Yeah.
So I will caveat this with my business, and what I'm doing specifically is talking about quality food. I'm explaining why different food products are different and how to find more nutrient dense foods. And one thing that does come up is a lot of the food that we eat today is pretty nutrient depleted.
Mhm.
And there is a lot of people seem to understand this correlation of eating nutrient depleted food does not create the same satiety as eating nutrient dense food. And is there a correlation with obesity there? And we don't have, actually proving this, right? But this up relatively frequently. Where in part, we're eating a nutrient depleted diet. And because our body did not get the, vitamins, the minerals, whatever it is that we need to sustain health, we continue searching for more food. And so that is one thing that has been interesting to follow. And again, this is all, very anecdote, but I am in search for nutrient dense food. And so, anecdotally, there's something called regenerative farming where we pay attention to soil health and just kind of on a common sense level. But although this has been well studied and documented, the nutrient density of the soil translates into the nutrient density of whatever grows out of it. And so that is true of food that we eat out of the soil if we're eating plants. That's also true for the food that animals eat out of the soil if we're eating animals. And so when people source and find really, really nutrient dense foods, I have a bunch of anecdotes now where the volume of food that is needed to feel satiating is significantly smaller. So it's been really interesting. Like, for example, my husband and I, we used to go to Costco and get this like massive piece of salmon, for example, right? And he'd cook the whole thing. And my husband, he's, 6 feet tall. He's trains for a bunch of marathons, works out a ton. He would be very nice and give everyone, at the table some salmon. And then he kind of always be staring at the leftovers. And then when it was done, he would consume a really significant portion of this quite large piece of salmon, right? We started getting salmon from this company called Zootopia. We get a whole bunch of it. They have lots of other products too, but just sticking with that one example. He can eat, the first day he ate 6-ounce filet. He thawed like 4 of them. I ate like half of one. My kids split the other half of one. And after that first filet, he was like so overstuffed. He made, so much more because he was just used to eating a much larger quantity. But there are some products, and this isn't true, for everything, but there are some products where you just really feel it. You feel so much more satiated. And there's also this massive correlation with flavor, which is really interesting. When we get really flavorful food, there is a proven correlation with phytonutrient density, with phytochemicals, with all of these other things that we don't really think about a lot with food that are beneficial for human health. And so there's a whole nother, conversation there. When we talk about food for health, there's been a lot of focus and interest on macros. Yes, there's fat in food. Yes, there's carbs in food. And yes, there's protein in food, right? And then a lot of people will talk about some other things. Some foods are maybe good for good sources of magnesium or iron or vitamin C. But there's this whole other class of food or other class of ingredients in food called phytochemicals. And so those are things like flavonoids, like carotenoids, antioxidants, right? Those things have antioxidant potential. And all of these other chemicals that have immune mediating effects and just so many other effects that are beneficial for health. And when we talk about our conventional food system, the density of those phytochemicals is relatively depleted compared to other farming systems and ways of agriculture. So there's lots of different conversations that we could have here. And I am not, a nutritionist by background. So specifically, I'm very hesitant to give a specific diet recommendation to a particular population. In particular, an obese population, because as we've said, there's so much that goes into that. But what I would say is, this is a lot of what I talk about. So happy to explain this, much, much further. But the nutrient density, I think, plays at least a role here.
One thing I'll add is over the years now that we've looked at all these different diets, the ones that you've mentioned, the one thing that always strikes me as like really frustrating is that you'll see a positive study. Oh, this keto diet, it does XYZ wonderful things for your health. But then you'll see in the next breath another study that says the exact opposite. And I think the conclusion that I've drawn is that there is no right diet. And really the right answer is exactly kind of what Akshita's saying, eating nutritionally dense foods that are not processed. And if I had to give anyone advice, it would be, honestly, it'd be that famous Michael Pollan quote that he says is like, eat food, not a lot, mostly plants. And that's kind of the punchline.
Yeah. And I agree. And that's something that we've also really encouraged our patients to do, which is to eat denser foods, right? Because they tend to be less in calories, but also less in terms of a carb intake, and less also in terms of processing food, right? Processed foods. So it's really interesting, and I agree with you guys. You know, it's not about one particular diet or this or that. I remember like for a while everyone was like, oh, coconut oil is really healthy, and then they're like, oh no, it's not healthy, and then I'm pretty sure next year they'll be like, oh, it's healthy. I give up. It is what it is. You know, I'm a big fan of coconut water actually, and so I try to get the natural one just from one of the Asian grocery stores, and I try to drink that quite a bit for hydration instead of like not just water, but instead of like Gatorade or something like that. And it does help, but it also keeps you more full compared to one of these processed energy drinks. And so, but I completely agree with you guys. Completely agree with where you guys are coming from. I think that's pretty much all that I wanted to talk about. Is there anything else you guys want to talk about?
I think we covered
so
a ton.
much more, but only so much.
Oh yeah, so much more.
So much more that we could. But just to kind of harp on what you were saying. Yeah, I mean, looking at the quality, right? I think we have to go so much further beyond just coconut water or not, because our system is not that simple. It's like the supplements. It's like these peptides, right? It all matters. Everything matters of what else is in there, right? What else has happened? An apple is not just an apple. We have an entire life cycle that we need to think about. When was that harvested? How is it stored? How is that transported? What is either put on that or not put on that? How are we cooking with it if you end up cooking with different ingredients? But how does that translate, and how does that make a difference? And so there's just so much more that I think we need to ask. And what Divya said, I just don't think that there is a diet that works for everybody. I think we need to kind of pay attention to ourselves and what makes you feel energized, what makes you feel satiated. I think, those are things to pay attention to.
Totally agree. Totally agree. Well, thank you guys. Really appreciate it. We'd love to have you on the podcast again, and vice versa. It was great. Fantastic. And I learned a lot. I hope you guys learned too.
Yeah, this is really awesome. Thank you so much for your time.
Yes.
This is so fun.
Thank you guys.
Thanks for tuning in to Dive into Health MD. Our goal is to empower you with knowledge to better understand how your daily choices influence your health. If you enjoyed this episode, consider sharing it and subscribing so you don't miss what's next. Please remember, this podcast is intended for educational purposes only and should not be considered medical advice. For personalized guidance, always consult your physician or a qualified healthcare professional. Wishing you physical, cognitive, and financial wealth. See you in the next episode.